Good morning. Welcome to the February 15th, 2018 Public Health Nursing Webinar. My name is Joy Hoskins. I'm the Chief Nursing Officer here at the Department for Public Health, and I'm so glad that you all could join us today. We've got a full agenda, and we'll be starting off with Dr. White as our first speaker. I wanted, though, to say thank you to someone who has been behind the scenes for many years for the public health nursing ITVs and now webinars. Tony Leeser with the Education Workforce Development Branch has been here several years, has always been so helpful to me and to you all, I know, as far as train questions, building all the public health webinars in train. She works behind the camera and makes sure that there's an archive version for you all to view. And she's going to be leaving us at the end of March. She's going to get married and leave Kentucky. And so we wish her all the best and happiness in the world. And I'm sure EWD will continue to take good care of us in the webinars. But I wanted to send a special shout out to Tony because this will be her last webinar with us. So with that, I'll go ahead and ask Dr. White to come up. As you all have heard, Medicaid, as we know it, will be changing effective July 1st of this year. And so Dr. White's going to share with us a little bit what those changes are going to look like and what they'll mean to Medicaid beneficiaries and to us as providers, Medicaid providers. So thank you, Dr. White, for joining us today.
Well, thank you, Joy. And I didn't realize this was was retired. This is news to me. So congratulations. She's always tried to make me look good on these things, and that's always helpful. I do appreciate that, and congratulations. We're going to talk a little bit about the Medicaid waiver. Oh, thank you for changing that slide.
Yes,
I appreciate that. I was panic-stricken when I saw that this morning. I had done this presentation earlier, and I had a different title slide, so thankfully Joy changed that to the Public Health Nursing Webinar. Do not panic. This 20 minutes that I'm going to talk to you is not the only time that you will hear about this. This is just a really quick overview and the parts of this that I think are important to public health. The cabinet has been working on this Medicaid waiver since January of last year. There were meetings, all-day meetings, Tuesday and Thursday, every week for like 3 months that I went to because public health is part of this waiver, and I wanted to make sure that we were at that table. So meetings are still ongoing. This is a huge lift to get all the moving parts together. So I just wanted you to know that there is a whole committee on communications, and that committee's job all along has been figuring out how are we going to get this message out. That committee couldn't do anything until the waiver was officially approved, and that was just approved in January. So now they're working on how can we get this message out to all the people that need to know so that we can then relay this to the patients that we serve and the people that we care for. So this will officially go into effect July 1. And the part that we're going to talk about today, the waiver, the My Rewards part, will actually go into effect April 1. So let's start by talking about, I need to do, just click on it, okay.
Yeah.
So let's talk about what the Medicaid waiver is not. And I think that's really, really important. So if you've been asleep up to this point, wake up for just a second. This slide is the slide that you want to circle and take home with you. Stick it up on your pin board. That's a new thing I learned. Pin board is some kind of a social media thing. Oh, yeah. Oh, I didn't know that either. So anyway, put this somewhere where you can find it, because what you're going to see is start at the bottom, in children, there is no change to benefits. This waiver has no effect on children. So children up to the age of 18 will still have their Medicaid state plan. Pregnancy category, there is no change in their benefits. So just as you've always taken care of pregnant women, that is going to be the same. Now let's go up to the top where we look at the adult group. that Kentucky Health, and HEALTH stands for something clever that I wrote down for my last talk that I forgot to write down this time, but trust me, it stands for something clever. We always do clever acronyms in state government. But if you are a medically fragile adult, and I was on the medically fragile committee, that definition is very, very loose. So if you are a diabetic that cannot work or do community service, you will have no change in your benefits. If you are someone with an opioid disorder that is really not functional, doing some kind of community service will be part of your recovery, but not at the very beginning. HIV patients are in the medically fragile category. So there is a whole host of medically fragile people, and all that person needs to do is get an attestation from their provider. There'll be a form for them to fill out. And when that person gets put in the medically frail adult category, then they will not be a part of the Kentucky Health Waiver Program. That's really important, because that's a lot of the concerns I hear from advocates, and that's not going to be the case. Former foster youth up to age 26, they will not be a part of the waiver. So when they age out of foster care, then they will go into this group. So they will still have the regular Medicaid state plan that we're all familiar with. Parents and caregivers, caretakers. So if you are a family of 4 and you have there's a wife and a husband and 2 kids, and the husband works but the wife does not, if she's a caregiver of those small children, she will also be in the Medicaid plan and will not be part of that considered able-bodied group that will then go into the Medicaid waiver system. Okay, now this slide, for anybody that knows me knows I did not put this slide together, because I would never put this many words on a slide. But just to give you the big picture, the Kentucky Health Program has 6 different areas. That's a hexagon. I was a chemistry major. I should have known that. There are 6 different parts of Kentucky Health. We are going to focus on the My Rewards, which is in the upper right-hand corner. But I want to give you just a real brief overview of what this program is. They tried to model this program after the Kentucky Employee Health Plan, the same plan benefit that I have. That's one of the reasons that dental and vision is not included in this plan, because I don't have dental or vision either. Fortunately, I know enough people. My best friend in college was a dentist, and my neighbor who I used to practice next to me is an ophthalmologist, so I've been able to manage without having to get a benefit plan for dental and vision. But state workers, unless they buy a separate package, don't have vision and dental. So that's why this Kentucky Health Plan for the able-bodied folks doesn't have vision or dental. So the first box, we'll start with the upper left-hand corner, cost sharing. That means that just as people with insurance have premiums to pay, people in the Kentucky Health Program will have premiums to pay. Now, sometimes the premium is $1 a month. It can go up to, after several years, up to $35 a month. That is for the whole household. That's not per person. So if you have a family, then it's $35. It's $1, $10, depending on your income level. So that will vary. The cost sharing is an effort to try to get people involved in their health care, just as you and I with insurance have to understand our own health care. The reasoning for going to premiums, I was told, is because having people pay a copay every time they show up, this will eliminate the copays. So having to pay a copay every time you show up might hinder you from going to the doctor. And so if you just have to, and it's unpredictable. If you know you're going to have to pay $10 every month, and you can budget for that $10 every month. If you don't pay your premiums, then you do go into a copay system, and that's getting more involved than what we're going to talk about today. But cost sharing is a way to get people that are on the Medicaid system involved. They already pay some copays now. This would eliminate that and take them to premium payments. The deductible account, that's at 12 o'clock on this slide. The deductible account has given a lot of people a lot of heartburn, because they're concerned that once people reach their deductible, then they're going to have to pay out of pocket. That's not the case. case. The reason for the deductible account is for people to start to pay attention how much money is being spent on my health care, and you'll get a deductible statement just like you and I would get a deductible statement. So there's a $1,000 deductible. People can see that $1,000 go away over time, but once that $1,000 is met, they do not have to pay anything out of pocket. It's just a teaching tool. The whole program is a teaching tool trying to help people get themselves out of their poverty situation into a working situation, into a position where they'll have some health insurance coverage, and then that way they'll understand the program a little bit better when they get into a health insurance coverage program. In the bottom left-hand corner is premium assistance, and this is a real interesting concept. When I was in practice, I can't tell you how many patients would come to me and say, gosh, they want to give me a promotion at work. And I said, oh, isn't that wonderful? And they said, no, I turned it down because I would make too much money and I would lose my Medicaid. What the premium assistance is it's a way for people, if you get into a job that has health insurance coverage in your job, but then the Medicaid will pay your premium, which is cheaper than paying for your health insurance, and then that way you can stay in your work, the place that you work, or into that insurance plan, so you don't have to make those kinds of decisions. The three boxes on the right-hand side, education and training and PATH program. These are the things you've heard a lot about in the newspaper, and these are the things where if you are a member of Medicaid in this able-bodied group, not that group we talked about earlier, but just in the able-bodied expansion group, they are going to require that you do some kind of activity in order to maintain your coverage. And that's going to either be working so many hours a month, that's going to be doing so many hours a month of community service, that's going to be working on your GED, that's going to be going to the job centers that are around the state looking for work. All of those things would count toward, and going to school if you're actively a student. All of those things would count toward your PATH program, and that would show that you are trying to improve your skill set so that you can then go on and get a job where you can get insurance coverage. Education and training at the bottom is looking at health literacy and financial literacy. Those are some programs that you can do to give yourself rewards in the My Rewards account that we're getting ready to talk about. It's also a way, if you didn't pay your premium and you're in the copay group, and you're at risk of losing your insurance because you haven't paid your premiums. If you take a health literacy class, that's an on-ramp to get you back into the Medicaid program. So it's used as a reward or a way to get back around missing payments and missing premiums. Okay, so enough about all of those things. That's just a really quick overview. We're going to talk about the My Rewards account, and this is the part where public health departments I think are poised to play a really critical role. The My Rewards account is very similar, for those of you who have state insurance, to our Go365 account, or I still call it the Humana Vitality account because that's easier for me to say than Go365. So if I slip and say Humana Vitality, you know what I mean. It's like calling people by their maiden name, even though they've been married for 10 years and just, you're used to them being that name. If you do things, extra activities that are helpful to keep you healthy, you're going out of your way to do something that is preventive for you or your family, then you will actually get dollars into an account called the My Rewards account. Now we get points into our Go365 account, and you can go online and buy from the Go365 mall. This is actually dollars that will go into your My Reward account that you can use at a later time for either vision or for dental care. So as you do these things, then you can grow that amount of money, and if you then get a job and leave Medicaid, you can take up to $500 of that money with you as real cash, not monopoly money, but greenback dollars, the real thing. The expansion population, or who this impacts, if you are any of those things, that third box down, if you are an expansion, if you're a caretaker, if you're medically fragile, foster care, pregnant. You remember I told you this new program doesn't affect you. You can actually be in the My Rewards program even if you are in those areas. That's the only way that the new waiver affects the pregnant and the medically frail. If you want to build up points in My Rewards, you are allowed to. You don't have to. So it doesn't impact children, and it doesn't impact the non-Kentucky Health Medicaid members. This is a very busy slide, but just to give you an idea, and this is by no means complete. In fact, it's by no means accurate, but it's as close as we've got right now, of things that people can do to be a part of the My Rewards program. They broke it down into the community engagement on the right, and we've talked about that, registering at a career center, community activities, job skill training, conducting a job search, actually being employed or working on your GED or passing your GED. All those things count for your community engagement. On the left side are educational training. So the MCOs are supposed to get a health risk assessment on everybody in their MCOs. Well, it's very small percentage of people actually do that. And that would be very helpful for the MCO to know how to target education and trainings for you. So if people complete their health assessment, then they get dollars in their My Rewards account. If they do a diabetes self-management class, or if they do a chronic disease self-management class, those kind of classes will count toward My Rewards dollars. We're working on a way to find people that complete the HANDS program could get dollars for that. I'm working on moving. Now, every one of these is not going to start happening July 1st. Don't get excited. I'm calling it phases. I thought I was going to get everything at first, and now I'm finding out I'm getting phase one. Phase one is going to be just a piece of this. Phase two, though, I'm hoping will get us moving beyond depression. If you participate in that, you can get My Rewards dollars. The WIC program, as you all know, getting people signed up for WIC is one thing, but the actual way that we as a state get money from the feds is the people that go to those 3-month visits. And I know how hard health departments work to get those 3-month visits done. Well, if you come for that 3-month visit, you will have a $1 incentive for showing up and having that 3-month visit done. So that will impact the program, which will allow us to get more money from the Department of Agriculture so we can try to beef up our WIC program as much as possible. Another thing that Gary Ramsey, who is the person in Medicaid in charge of this, he's actually going to allow you to get dollars from your My Rewards account if you will allow the state to text you. Because he's very social media savvy. He wants to be able to text Connie, it's October, and our records show you haven't had a mammogram this month. What can we do to help you get your mammogram scheduled? Not a mass mailing. There's a huge percentage of mailings that come out of Medicaid that come back as undeliverable, but people usually keep their cell phone number. So he wants to target every individual in Medicaid with what do they need to know, and what do they need to know that we can help them with. But you have to have people's permission to text them. So that would have to be part of the My Rewards. Getting down to prevention, which is some more of what we do, is if you do any of the American Cancer Society preventive screenings for breast cancer, lung cancer, cervical cancer, or colon cancer, you will get dollars in your My Rewards account, or get a flu shot. You'll get dollars in your My Rewards account for doing those things. If you take your child for their physical examinations, obviously children can't take themselves to the dentist or to any other care, but if you as the parent take your child somewhere, you get dollars in your My Rewards account. And so you can read through the rest of these. The one on the healthy living side, smoking cessation activity, I was very excited about this because I know that we offer the American Lung Association Freedom from Smoking class in all of our health departments, but I know we offer it very infrequently because it costs money to do that. So I was hopeful when I saw this on the list that meant they were going to start paying health departments for doing the program. Well, I just found out a few weeks ago that that's not in the plan. So we started working with Medicaid, and I just sent an email out to the health department directors last night, and I'm going to get that email to Joy so she can send it to all the nurse leaders. But we have gotten Medicaid to put in a change order, which around here means a lot. But a change order is a request to add a particular code, S94 something, I don't know, it's in the email. And that code can be charged for every person that comes to every session of the Freedom from Smoking class. So the charge will, after the Medicaid match is paid, will be about $14.52 for every health department. So that you're going to have clients calling you saying, we want to go to a smoking cessation class, and this will be a way that you can actually charge every single one of those folks that comes if they have Medicaid, and to help reimburse some of the costs. So we sent that email out last night. We actually had a director say, I just really want to do these for free. That's fine, but I wanted you to know that we have we've come up with this with Medicaid, and we're very excited about that. Obviously, drug addiction counseling we're not going to do. Working with First Steps, they want to incentivize people to do that. Inappropriate emergency room visits, and this one is interesting. If you do an inappropriate emergency room visit, they can actually take $25 from your My Rewards account. They want you, the last one on there is, if you go to the ER and you're supposed to follow your primary care and you don't, again, they can take money out of your account. They're trying, excuse me. Sorry, I got a tickle in my throat this morning. I didn't know I had. They're trying to get people to be involved in their own health care. So this is the timeline that we're looking at. January was when we found out as a state that we were approved for this waiver. April the 18th, on the 1st of April, is the first day that you can actually start earning My Rewards. The waiver doesn't go into effect until July 1, but they wanted to set it up so on April the 1st, you could start doing things to build up your My Rewards account. Excuse me. Because July the 1st, they didn't want everybody to suddenly have a My Rewards account with a balance of 0. So people can actually build up My Rewards dollars into their account starting April the 1st, which is why I wanted to get that email out about smoking cessation classes, because that might inspire some health departments to start sponsoring those, maybe around that time in April or May or whenever. So this is a real quick and dirty look at what's going to be happening. I know that we got an email just this week that the communication department is starting to plan their education. We've told them from the very beginning that that their clients are going to be coming, excuse me. Their clients are going to be coming to the health departments asking questions. They're going to say, explain this to me. Y'all don't know what's going on unless you are trained. So they're going to start doing trainings. They're going to start doing recording some of those trainings in some modules, so they'll be available for everybody, because the health department directors are not who needs to be trained. It's going to be the nursing staff. It's going to be the front desk people. It's going to be all the folks that work in the health department, because this is going to be a huge culture shift for people to start to understand what is insurance, how does it work, what's a deductible, what's a premium, why should I pay a premium? I didn't go to the doctor this month. I mean, you might ask yourself that question as well, but when something happens to you, you're very glad that you paid those premiums. And this is not a culture that folks are used to. Nobody in the United States is used to this culture. It's interesting that many of the things that we're doing in Kentucky were done in Indiana, not the work program part. You could actually pay your premiums at Walmart's in Indiana. So they're trying to think of how many different, and I don't know if that deal's been worked out in Kentucky, but they're really trying to think of creative ways that people can pay that premium. They don't have to go to the DCBS office to do that. A lot of moving parts, as you can imagine. If I go and get my mammogram and have a dental issue the next day, will my Rewards dollar for getting my mammogram be in my My Rewards account if I have a tooth extraction the next day. Dentists are going to have to go into a portal to see if you have enough money to cover that dental extraction. It's still, I mean, the next, you can't, for the folks that are not in this room, next door, they're working. That's why these meetings have continued to go on at least daily and several times a day with different IT vendors and all kinds of different ways because this, to work well, is going to have to be a very slick IT machine, and they've got some of the better minds working on that. And I think if anybody's going to figure this out, it's going to be this group of people that are working on it. So what you will expect to hear from us here in Frankfort are educational programs trying to help people to understand. There will be assisters, as we've had for the Medicaid expansion. There will be assisters that will be helping with this. So getting folks trained and making sure they understand the program is part of the next task now that this has been approved. So can I take questions from the field?
Do we have those?
Or you can.
Jamie's gonna check. I have one, Dr. White.
Okay.
While Jamie's checking it from the field, how will we learn about new options or My Rewards benefits? You mentioned, a phased-in approach. So how will local health departments learn about updates and new opportunities?
Well, I know that the communications group is planning on some kind of newsletter or something like that. But what I would think that DPH needs to do is we need to go through that and glean all the information out that health departments need to know, and then figure out some way that we have a communication newsletter, or this is the latest news from the waiver as those kinds of things come out.
Okay.
Mm-hmm. I went over to talk to the My Rewards committee. They gave me 10 minutes on the agenda. 45 minutes later, I sat down because I took every single thing that we do at a health department, from lead testing to everything that we do, and tried to show them that all of these should be part of the My Reward system. I think I overwhelmed them a bit, although they kept asking questions. But for them to understand, as usual, they had no idea of the breadth and depth of what a local health department does. So I got a few of the things we did okayed. And so it'll be a continuing way to try to incentivize people to come in and use the services, car seat safety, all kinds of things that you do already. And if we could incentivize people to come in and participate in those, you would have a much deeper reach in your local community.
Jamie, do we have any questions?
Rwanya Rice says, hi Rwanya, will this program have a symbol, quick visual that can be included on HD advertisement for health education classes that qualify for the program? That's a really good question. I think on the very opening slide, that little yellow Kentucky with the Kentucky and the health all capitalized, I believe that's the branding that they've used, and they have hired a management firm that's working with this communications group to try to make that branding something that everybody understands. This symbol attaches to you if you have Kentucky Health. So that's a great question, and we'll need to be sure that we send you that in a pixel thingamabobby, JPEGgy. The IT people are laughing at me. Whatever that is that makes it nice and crisp and clean, because Rwanya knows how I can't stand symbols that are all blurry edges and make me feel like I need to change my contact lenses.
I've got a question.
Yes.
On the emergency room visits, will they be sent a list of things that would disqualify them for that emergency room visit?
That's a good question. The question is, will the participants be sent a list of things that do not qualify as an emergency room visit? I've not been in on those meetings. At the very beginning, I think what they are hoping people will do is there's going to be a phone number, like a call a nurse. You call the nurse and say, A, B, C, and D are happening to me. And if that nurse says you need to go to the ER, you go to the ER. If that nurse says, maybe you need to do this, this, and this, and they go to the ER, that was way back in the beginning. I don't know how sophisticated that's gotten right now. But certainly the impetus is to keep people out of the ER. They can just wait till the next day to see their doctor or nurse practitioner.
Are there any other questions from the field?
Well, I apologize for the hacking attack that I had here, but this is not the only time you will hear about this. I'm sure that as things progress, Joy will have me here to let y'all know more as it progresses. But it is a moving target right now, and because as it gets closer to the real deal, the pressure's on. The country is looking at Kentucky to see if we can get this right. So let me know, let Joy know, let somebody know. Things that you hear. I think there's more talk about the waiver that is inaccurate than there is talk about the accuracy of the waiver. So I want to be sure that, whether you like it or not, you need to have the facts and you need to have them correctly. And I do know that I've been extremely impressed with the group here that's leading this. Christy Pullum is just top notch. And they really are pulling public health in to make sure that everybody's needs are being met. So there'll be more to come.
I think it's remarkable that it only took you 45 minutes to talk about 144 different programs. Thank you, Dr. White, for that very informative update, and we will look forward to having you back as more information is available. Next, I'll go ahead and invite Angela Kick to come up. Angela, you all may have met at our last public health webinar. She is our brand new nurse in the public health preparedness branch. She started with us at the beginning of January, on January 2nd. She probably would have been here on January 1st if we would have been open. So Angela's going to talk to us a little bit about her roles and responsibilities. I think this is kind of gelled a little bit. And as far as from what we knew at the beginning of January to now, and she's going to be already is truly an asset to the department, and I know she'll be an asset to local health departments and serve as a great resource and provide technical assistance to you all. So I wanted to make sure to get her out in front of the camera to talk to you all, give you all a little bit of idea of what she's going to be working on, so you'll know who your point of contact is in the areas where she's going to be. So thank you very much, Angela, for being here. We'll get your PowerPoint pulled up for you. And Jamie's already done it. Thank you, Jamie.
She's on it. Yeah. So did I hit enter to go?
Yes.
There we go. All right, good morning. I'm going to keep saying that I am the new preparedness nurse, and I'm going to try to use that as long as I can, hopefully about the next year. I'm just going to give you a little bit of my background and where I've come from so you kind of understand my expertise. Public health nursing is very new to me. So that's the one area of nursing I've really never touched on, even though with emergency room nursing, it kind of falls into that a little bit. But I started out in critical care and open heart recovery. So hearts are still my first love and will always be my first love. And then I went to a brief stint in the emergency room where I did a lot of precepting. I was a charge nurse, and I decided to go to the air at that point. And I basically was a flight nurse for about 10 years. I was a flight nurse here in Kentucky. So a lot of people kind of remember me when I used to fly out in Eastern Kentucky, but then I went down to Vanderbilt. The next thing that I did was supervisor in the emergency room, and then I became a director in the emergency department. So I deal with a lot of policies and procedures. So with this job, that's been a world of help for me. I've also worked for the last couple years as our coalition in Region 15. I was the chair of the coalition. So the HPP side I know very, very well. I am learning the federal side of this job. And so you're probably wondering, how does all that fit into what I'm going to be doing here at the health department? So month one, if you notice, I put a tornado on month one. It has been a whirlwind introduction to public health. So a lot of things that I'm doing right now, I'm working daily with the hepatitis A outbreak in Louisville. I'm also working with a group in Northern Kentucky for their issues up there. And then one of the big things I'm going to be doing is a nurse strike team development. And I am working with Joy with that. We've had lots of conversations, and I'm finding my starting point for that. And that's kind of go along with our medical needs shelter. We do have a book. I'm sure lots of you have seen that book, but I'm going to try to separate that book out a little bit more into policies and procedures. And keep then the skills book for our skills. So we will be having some more medical needs shelter classes in the future. My plan is for this nurse strike team is I would like to get about 20 nurses throughout the health department. So start thinking about that if you would like to be part of our nurse strike team. I'm more going to have RNs. I am thinking about having maybe about 4 LPNs along with that 20 people. So when we pull these teams together, I can have a team of 8 RNs and 2 LPNs. This is going to be for in-state and then out-of-state deployment. I can see the in-state being, we're going to be using a lot more than our out-of-state. But as you all know, we did take our first nurse strike team last year to Florida, and I heard they did a wonderful job and got wonderful reviews. So I'm excited about starting that. Along with that, on those same lines, I'm looking at everybody's nurse to go bags for your local shelters. And I actually met with one of the preparedness people in Jessamine County and talked to a couple of the nurses at that health department and looked at their bag. So what I would like to do is put together a list of supplies that could go into your nurse to go bags for your local shelters. And it would be a suggested list. So every area may have something slightly different, and that's fine. But if we could kind of standardize that bags, I'm just thinking about having the equipment, be able to get it maybe more at the bulk prices. So be looking for that out in your community. I'm also working with patient tracking. Kentucky, we do use it's called Resource Bridge. Right now it's suggested, but that is going away. And everybody is familiar with the ReadyOp. I'm sure that I don't know if that's a bad word to you or a good word to you, but it's actually a great system. So I'm looking to see if we could possibly use ReadyOp for a patient tracking situation. And patient tracking is extremely important, especially when we have these large-scale MCI events, or even such as in Marshall County a couple weeks ago, the shooting, is how do we track our patients? So especially if you all are out in the shelter, how are you going to track a patient if you're sending the patient to now a hospital? So it's for family reunification, and we're talking about even changing the name from patient tracking to some type of reunification system. So I think that's exciting, and I'm hoping to have a system ready to go and online by September. And that may be pushing it a little bit, but that's where I'd like that to go. The next thing that I'm going to do is I'm taking the lead on fatality management. This is a huge undertaking. The lady, J.C. Logson, who's doing it right now in Somerset, has done a fantastic job on that. So I am trying to get my feet wet with that, and I'm hoping by July that I'm taking full lead on that. And then just learning the technology. There's so much technology here that I have not worked with before, so that's been real interesting. So things to come. What do I see coming down the pike? You're going to be seeing me. My plans are to get out to each part of the state and visit. My next visit is going to be in Elizabethtown, so I'm going to be coming to those health departments. But I'm going to try to work with our regional preparedness person so they can take me out to visit and meet everybody so everybody can get familiar with me and what I'm doing. I'm going to be part of the Pediatric Emergency Care Coalition and on the assessment team to check for pediatric readiness in our hospitals. I'm also going to be on the Ebola assessment team. So I'm getting ready to go to class for that. I'll again be working with EMAC and trying to get Mission Ready package ready for our nurse strike team. So I'm hoping that I can have that put together by the end of this year. That's kind of, I really probably need to have it by the summer. And then developing some additional training for our medical needs shelters. I'm sorry, I have special up there, but it's medical needs shelter. And collaborating with several of you out there for getting that done. And then one of the things you're going to be seeing very quickly is you're talking about the respiratory program in all the health departments. So there's been a need that has been brought to our attention about some potential fit testing training, a train the trainer coming out to the departments and the equipment. So I'm going to be working with NEC in putting together a survey with the leaders of the health departments. So hopefully we can get those surveys back here in the next month or two so that we can ensure that all the health departments have what they need to be successful with a respiratory program.
Would you mind just to share with the group a few of the questions that we'll be asking on the survey?
So a couple of questions that we're going to be asking on the survey is, one of them is probably equipment. Tell me about the supplies that you have, the expiration dates on them. So what we have found through just some general questions are that some of the supplies, such as the solutions, the sweet and the bitter solutions, have been expired. The other thing we want to know is, or question we maybe ask is, where are you having your fit testing completed at? Some health departments actually have kind of contracted with their local hospitals. So the nurses at the hospital are actually doing the fit testing. Some health departments are actually doing their own fit testing. And either way is perfectly fine. We just kind of want to have a better understanding of what all the health departments are doing. We may be asking about if you have a negative pressure room. I know a lot of health departments have built new buildings, and we just kind of want to get a general understanding about negative pressure rooms if one was actually built within that. So is there anything else? Does anybody have any questions for me? Is there a button?
Angela, if a local health department has a upcoming training, or they have meetings, the regional meetings, or that they would like for you to attend, if there's a nursing component, a clinical component, would you be available and able to attend?
Oh, absolutely.
Sure, you might want to share that information with them about your availability. I know one local health department is preparing. I just saw their just did their nursing Cs. They're going to have a one-day tabletop exercise and the N95 fit testing and so forth and so on. So I hate to add to your list, but would that be something that should be available to do?
Yeah, I'm excited. I want to come out to the health departments, and I want to meet the nurses, directors, nurse leaders of the health departments, and just see how I can help you. And you can help me with my experience with public health nursing. I mean, it's going to work both ways, but I would love to come out. So if you do have a special training coming up with clinical, you're doing some type of shelter training, I would love to come out to it. Just my email, I'm on regular email, but it's angela.kick, and it's K-I-K. There's no C, I promise. But it's angela.kick@ky.gov.
And does she have a question? Does she have any questions?
No, no. Thank you.
Thank you, Angela, so much. And as you can see, Angela's busy like all of us, and she's been great to work with. So more to follow from Angela. Next, I'll ask Troy J. Cunningham to come up. She is the woman of the hour in regards to influenza surveillance. Busy time. in Kentucky with influenza, and Troy is certainly our go-to person as it relates to updates, data, morbidity and mortality numbers. And so thank you for coming with us to talk with us today, Troy. I'm glad you're feeling better this time. I think the last time you were not feeling
No,
well.
not feeling right. I didn't have the flu. though.
No, that's right. You're back to your good self.
Yes, I hope so.
Okay, you're all ready to go there. Thank you, Troy.
Thank you. Well, good morning. I appreciate you all being here. My name is Troy Cunningham, and I'm the influenza surveillance nurse for the Department of Public Health. And as you know, we're having a very busy season this year. I'm just going to go ahead and jump into it. We have a lot going on. I've had a lot of calls wanting to know the comparison of what we're seeing this year compared to previous years. So this is a pretty telling slide right here. In comparing to last year, we had 76 deaths, total, no pediatric deaths. This year, as of last week, we had 102, with 4 of those being pediatric deaths. Now, what I can tell you is that the majority of those patients that have died have had a lot of comorbidities. There's a very small percentage that have been truly healthy without something else going on, but that's not a reason not to vaccinate. So, you know, we're still saying vaccinate. There are a lot of other strains. There are 2 A strains and 2 B strains that circulate in our communities, and you know, the vaccine takes care of all of those. So, you know, you may not have had one, but you might end up with another. And as we've heard, people are getting the flu twice and getting different strains. So the flu vaccine is definitely our best bet. You can see that we've had 5,264 cases already so far this year. And there's something to be said there. There's some changes in the technology and type of testing. There is a PCR test that's considered to be laboratory confirmed. And then there is a rapid molecular test that's now available and approved by the CDC that is actually a point of care test. So they can get those results quickly, and a lot of practitioners are actually using those, as well as hospitals. So that kind of accounts for the large increase in number, although it definitely doesn't by any means say that it's not as severe this season as it appears. So how did we get here? The Northern Hemisphere, which is the United States, our flu season is really kind of a follow-up to what happens to the Southern Hemisphere, and that would be Australia. And y'all have probably heard that Australia had the worst flu season they've ever experienced, with 2.5 times the number of cases and hospitalizations. The media first said that the flu vaccine for the H3N2, which is the predominant strain in their outbreak, was only 10% effective. The media here in the United States picked up on that, and that's what they've run with as far as the vaccine effectiveness here. That has yet to be determined, and we should have the results on that in a couple of weeks. But actually, when Australia went back and did their end of season study, the efficacy was 33% against the H3N2. Now, we certainly would like to see it higher than that, but it's certainly better than 10%. So everybody always wonders, why can't they get this vaccine right? And it's actually a really long, involved process. If you know anything about genetics or have had any dealings with genetic testing, it's very, very involved. So every year, the CDC tests more than 1 million patient specimens to see what is going on out there. About 90,000 are tested in our public health labs across the nation. About 5,000 of those flu viruses, the CDC conducts full genetic sequencing. So they get down on the molecular level of that virus to see, to break it down as to what exactly they're dealing with. 2,000 of those flu viruses are then broken down even farther to determine their immune properties. And then there are about 50 viruses that they select that's possible for vaccine production. So even though we're saying there's an H3N2 strain, there could be 10,000 different strains of H3N2. It's about getting into that molecular level of the virus itself. So it's not very easy. And then we have the problem of antigenic drift and shift. Antigenic drift, and let me preface this by saying that this only occurs in influenza A. Influenza B does not drift or shift, or at least thus far. Let's not talk that into being. The antigenic drift is when random mutations occur in the genes. And a virus, one reason why it is so hard to address a virus is it's constantly mutating. It's the reason why we've never found a cure for the common cold or for HIV. Those viruses are constantly mutating. So as those H and N antigens change shape, they're confounding the immune system, where the immune system really doesn't know how to respond to that. And because of that, by the time they've taken all this time to select the virus to put into the flu vaccine, in the meanwhile, the virus has been doing its little thing over here and has possibly even shifted from what we're seeing in the vaccine to what is actually occurring in the atmosphere. The antigenic shift is a bigger problem, and that doesn't happen often, thank goodness. But that's where there's a really profound change in that H and N mutation into the antigen. And that usually occurs is when it jumps from one species to another. And an example of that would be the 2009 H1N1 swine flu pandemic. And that's the difference between a pandemic and an epidemic. A pandemic is going to be in a situation where you have a strain that's previously seen in animals and not in humans, and it jumps to the human population. There's concern in previous years about avian flu. If that had started shifting into the human population, then we would be looking at a possible pandemic situation. And this is a little slide that kind of gives you maybe for the visual learners in the group, an idea of what that looks like. So in the drift, we can see that our little antigens are just kind of warped. And they've just kind of gone through the fire, and here they are, and they're kind of melting. But in the antigenic shift is where we're taking pieces and parts of different viruses and making a whole new strain of virus. So what I'm going to do today, in October, I talked to everyone about what flu is and how to prevent it and how to contain it. And today I get a lot of calls every day about how to read this weekly flu report that I put out. And so that's what we're going to look at today. There's a lot of things that go into developing that report. Deaths, those are reported to us by the regional epidemiologists, hospitals, and I also do a death certificate review to see if there are possibly deaths that have occurred that have listed flu as an associated cause and hasn't been caught. And one thing about reporting flu deaths in Kentucky is it doesn't have to be the leading cause of death. In most cases, people are not going to die from the flu. They're going to die from the complications associated with the flu, such as sepsis, pneumonia, leading to organ failure and those types of things. So if it's listed anywhere on that death certificate that flu was involved, then we consider that to be a flu-associated death. We have outbreaks. We have long-term care outbreaks, and this year we're actually looking into community outbreaks in daycares and those kinds of situations. So we have had, as we said, we had 90 last week total for the year to date. And so that's a very vulnerable population, and it's actually where we see most of our deaths. And so those are always of great concern. We also have ILI surveillance sites, and that's influenza-like illness. The CDC has a web-based system that allows volunteers throughout the state to enter in their patients they've seen with influenza-like illness. And that is a really good tool for us and for the CDC to see what's circulating and how rapidly things are circulating in the areas. Unfortunately, we have 96 surveillance sites across the state, but we only have 20 to 24 that actually report on a regular basis. We're trying to figure out ways to motivate them to do a better job of reporting, but it also is one reason why you're not seeing on the map when we get to it that you're not seeing their cases in your area. And that's for a couple of reasons, but we'll talk about that in a second. And then the lab confirmed results. We think of going to the doctor's office and getting a flu test as being lab confirmed. And that's not actually the case. Those are more often than not rapid tests. And the rapid antigen test, according to the CDC, is not a reliable test as far as calling it a true lab confirmed test. It doesn't get down into the strain of flu. It will tell us that it's influenza A, but it won't tell us that it's H1N1 or H3N2. So, and in the rapid testing, there's a high false negative rate. And at this time of year is when to be particularly careful about getting a false negative result. If you go to the doctor and you have flu-like symptoms and the test says it's negative, don't necessarily be convinced that it's really negative, because due to the nature of the test itself, it has a high false negative rate when we're in the thick of things, which doesn't make a lot of sense. If you've got a positive test, you know you're positive, but a negative doesn't necessarily mean it's really negative. So this is kind of the trade-off that the practitioners are looking at. It's convenience versus accuracy. You can see by the PCR test, it takes 1 to 8 hours to get results. Well, we obviously aren't going to let our patients sit in the office for 1 to 8 hours to get that. But we know that it's highly accurate, and it can identify the subtypes of the strain. We go to the rapid molecular, which is the new kind of testing that the CDC has approved. And there are only about 3 types of those rapid molecular tests that have been approved by the CDC to count as lab confirmed cases. They can use those in the office at the point of care, at the bedside, and they can get results on those in less than 20 minutes. So that's definitely good. And we know that they're highly accurate. Some of those tests can identify subtypes, some cannot. And then we see the rapid antigen test, which we've all probably had. And that is able to be resulted in less than 15 minutes, but it's only 50 to 70% accurate, and it cannot get down to subtype. So we'll see there are a lot of A's when we get to a slide here that gives us our pie chart. And that's because they're just not, what they're using is not able to break it down even farther. So here's our ILI-Net surveillance site reporting. And this looks like it would be so easy, and I don't really understand why we can't get people to do this. But it is medical practices, university student health centers, urgent treatment clinics, and hospitals that use this. And they have a very specific symptom set to look at. There's a fever of greater than 100 degrees Fahrenheit and a cough and or a sore throat. So they have to have either a cough or a sore throat, or they can have both. But it needs to be without a known cause other than flu, such as strep throat. So what they do is they take the total number of patients that they've seen for any reason that week, and they put it into that next to the last column. And then they put their total patients they saw with flu-like symptoms in that last column. And then they break down how many patients they saw in those age groups. And that's all they have to do. They go online, they plug that in, and it's done. So if anybody has any suggestions on how we can make that easier, I would love to hear from you.
Or there may be some best practices, promising practices that, local health departments want to share with you, how they're
Exactly.
working with their community partners.
That would be wonderful, yes. If you have any suggestions at all. I do know that in the Northern Kentucky region, their providers are really good about reporting that to the local health department. They've got a really good buy-in with their providers. So perhaps that's something you can think about on your local level, is seeing if you can recruit even just a couple people to report to you, and then you could put that in for them, or you could send it to us. Okay, so this is an example of the flu report, and you'll see that we're always reporting a week behind. So this week's report that will go out tomorrow will be February 4th through February 10th. The MMWR week is always Sunday through Saturday. So last week we were widespread for the 8th consecutive week. I'll give you a sneak peek and let you know we're going to be widespread for 9. So here we go for last week. On the left-hand side, you're going to see how many new cases that we have that were lab confirmed. And again, that's only that specific kind of test. There's probably 3 or 4 times that are actually occurring in the community. But the ones that have had the PCR, or the rapid molecular testing, we had 660 cases just in that 1 week. There are 17 regions in Kentucky, and the reason it's 17 and not 15 is that Lexington and Louisville are considered to be their own regions just because of population. So 8 out of 17 regions had long-term care facility outbreaks. All 17 regions across the state had confirmed flu cases. There were 20 deaths, 20 adult deaths reported in that 1 week. 6 out of the 17 had increased flu-like activity, and there is an activity determination sheet that we'll come to in a minute that determines who we consider to be increased flu activity, and we'll look at that in a minute. But you can see that the numbers up there are pretty startling for the number of total lab confirmed cases, and from a slide a couple of slides ago, we saw that there were only 3,000 and some odd cases for the entire season last year. Now, the flu season runs from week 40 on the calendar year, so it started October 1, and it runs through week 20 of the following year, which would in this year means that our season will end May 19th. So we've got a long way to go. So to date, we've had 5,264 cases. We've had 90 long-term care facility outbreaks. Every region in the state has had confirmed flu, and we've had 102 deaths reported, with 4 of those being pediatric. Now, this is where people get this report and they start questioning why. You can see that we have white spaces in the Buffalo Gateway district and also down in the Purchase district. And a lot of that has to do with the fact that there's simply no providers that are using the PCR type of testing, the molecular testing. We know there's flu down there. We know that everybody's got flu, everybody's sick, but it doesn't reflect that on this map. And that's kind of frustrating for the local health department directors to try to explain that, especially to the media. But it is only just because of the type of testing that's being used. You can see over in Pike County, they've got a huge number, and that's because their hospital uses PCR testing on everybody that comes in the door with ILI symptoms. So it's huge. They're catching it. If everybody else in the state were doing the same thing, we'd probably have 30,000 cases. Who knows? You know, it would be a lot. But you can see different areas where they are using, you have a lot of providers or a big provider such as a hospital using PCR testing on everybody that comes through. So we can see that our kids from the age 1 through 10 are getting hit really hard this year. By far, well and above everybody else. We're seeing that the 61 to 78 age group is getting hit pretty hard, and also the baby boomers, the 51s to 60s. So that tends to be a little bit abnormal for the flu season. Usually we see the very young and the very old. We are having a lot of deaths in the elderly, but we're having a lot of illness in this mid-range, and that is indicative of the H3N2 season. And this is what I was talking about a few minutes ago about the type of testing and how it can get down into subtypes. You can see in Kentucky that the majority of the testing that gets reported is just called flu A. They're not getting down to the subtype of the H1N1 or the H3N2. And then we're seeing a strong uptick now in influenza B, and that's common. At the beginning of the season and at the end of the season, we tend to see flu B coming back into play. It's kind of our escort into the season, escort out. So I'm hoping that it means that our season may be dwindling, but so far we're not seeing a whole lot of that. But we have had a significant number of deaths that have been flu B, and flu B is normally a less severe and less aggressive form of flu. So that's something that's being watched nationally as well. So we can see that the week of January 20th was a big week for us. And it doesn't seem like that it's slowing down too much. But what we're seeing from that January 20th, some of that was a little bit of delayed reporting from the holidays. You get people together for the holidays and everybody's sharing germs. And so we know that in the next couple of weeks, we're really going to see some increased activity. This is the flu determination table that I was talking about a few minutes ago. So even in the areas that do not have practitioners that are using the PCR testing, we do still give you credit for having flu in your area, and that would be in category 2. So you will see a Y there that says there increased ILI activity reported. And that is used by, rapid testing is not reportable in the state of Kentucky. However, the regional epidemiologists usually do get a lot of rapid flu testing reports, as do we. And we still are looking at that to give that as an indicator of what the activity really is. So that's where that rapid testing is coming in category 2. So our formula is that it has to be category 1, which is outbreaks, or category 2, and then they have to have confirmed flu cases as well to be considered to be an increased activity region for that area. And most people are in that category. So we know that the vaccine is matching well against the influenza A, H1N1, the B Victoria, and the B Yamagata. And the vaccine efficacy data is to be released by the CDC on the H3N2 within the next 2 weeks. Estimates have been about 30%. So I think we're going to see about what Australia did. And there have been spot shortages identified by the CDC of antiviral medications and the rapid antigen testing kits. There have also been shortages reported of the vaccine. Kentucky, we don't have problems with vaccine. Actually, there's antivirals everywhere. It's just in spots. And so if you go to the doctor and you get prescribed with an antiviral, call ahead before you go to the pharmacy and make sure that your pharmacy has it. It might involve calling more than one, but your pharmacy will probably have it in the next day or two because they're just waiting for the distributor to get the medicine to them. The rapid antigen kits, the distributors are trying to up production on those, so that should not be a problem very soon.
It's very important, is it not, Troy, for the Tamiflu to be taken within is it 72 hours?
Yeah, actually, yes, 48 to 72 hours. It's very, very important that the Tamiflu gets started within that period of time to get the optimum results from that. The CDC is now saying that it can be taken later, that anything is better than nothing. But really for optimum results, you want it to be within that first 48 to 72 hours. So we do not have any shortage of flu vaccine. We've got a ton in the state. Still, I think we have about 45,000 doses remaining in our stock. So we have plenty. So please, we have a long way to go. We've just started. This is week 7 of the flu season, and we have 13 weeks to go, assuming that it stops in May 19th. We did see influenza B all through the summer last year. So just please continue to get your vaccine. If you are sick, stay home. Don't go to Walmart. Don't go to the movies. Don't go to school activities. When you're sick at home, keep yourself to yourself. Don't lay out in the family room with the rest of the family and you know, watch movies. Stay in your room by yourself. Make sure that your linens and your dishes and everything is quarantined essentially to that one room until your symptoms start to resolve. And you are considered to be infectious until you're 24 hours flu-free or fever-free, I'm sorry, without the use of Tylenol or Motrin. So don't cheat and say you don't have a fever. But if you don't have to take medicine to make the fever go away and it's been 24 hours, then you're good to go. So and that's all I have for you. I hope it's cleared up a little bit on how to read that report and what that means to you.
Are there any questions from the field?
There's a question here, is 317 flu vaccine available this year or next year? Yes, 317 flu vaccine is available. The only 317 vaccine is to be used for uninsured or underinsured patients, or in the instance of an outbreak. And it is something that we're in the process of discussing with the CDC as far as the definition of an outbreak with regard to 317 funds. If we consider an outbreak to be each one of these nursing long-term care facilities, can we use that for some of their staff? Traditionally, we know that CNAs are the lowest vaccinated group in a healthcare facility, and they're the ones that are giving the most care. So it is something that we're actually looking at and trying to work with, but there's also always 317 vaccine available. It's just a matter of working that out with the CDC to determine who can get it and use those funds. Okay. All right. Thank you all.
I do have one question for you, Troy. For the 96 surveillance sites that you mentioned, are the weekly MMWR reports sent out to all of those 96 sites, or are we asking local health departments to be sure to forward that information to their community partners?
On the report itself, when we send out the email, we ask that they do share that with any and all practitioners in their communities. It also does go out to the ILS sites.
Yes.
So everybody, hopefully it goes to hospitals, to their infection control practitioners. It goes out to hospitals. It goes to long-term care facilities, health departments, and anybody that you can share the report with, we would definitely appreciate it. And my time's up.
That means I can't ask you another question?
No. I'm kidding. What do you mean?
I just have one other question. How would a local health department know if they had a non-reporting surveillance site within their local health, their community or their district?
The regional epidemiologists have a list
Okay.
of all of the ILS surveillance sites in their region. They've been instructed to reach out to them and see how they can help them. I do have someone now that has just been brought on board to assist me with all the flu activity. And so one thing that she is going to be focusing on is contacting those ILS sites and trying to find out what can we do to help you, what are the obstacles in getting that reported, and how can we work together to try to improve that. So
Thank you for letting me squeeze that last question.
well,
That's an excellent presentation, Troy. Thank you very much. And one of the ways that I always know it's Friday is when I hear from Troy and she's sending me the weekly influenza surveillance report. So thank you for that great communication and all that data that's so helpful to all of us. Next, we have the TB program staff, prevention and control program staff. We've got Emily Anderson, Ruth Willard, and Maria Dalby here with us today. So thank you, ladies, for joining us. I know that they've got some good information to share, and they've got two of y'all have your scarves on, so we're ready. You're matching.
I'm going to talk about that.
Oh, well, sorry, 3 of them.
That's why we're there.
Oh, I got you. Sorry, I just stole the show. I'm sorry. Yeah, I want one. Yeah.
See, now you gotta give her.
Thank you, Joy. I'm Emily Anderson. I'm the TB program manager, and I just wanted to have everybody step into the camera team, the whole TB team's here, and we have these beautiful scarves on today, and it's to help promote awareness for World TB Day, which is March 24th. And I don't know if you can, I'm going to try to hold it up, but there's the little microbial rods that our microbiologists see when they look under the microscope. It has little rods, but they're really nifty. So the team has them on today, and we're going to have some information to help you celebrate and promote World TB Day. Maria's here with us. Which side are you on? I'm backwards. Sorry.
No, we got you backwards.
I'm backwards. Sorry. And then I'm going to introduce one of our newest members to the team. That is Ruth Willard. She is our nurse educator. She actually joined us almost a year ago, right? April in 2017. So many of you have met her, and we're really, really proud. She just recently completed her doctorate in nursing practice, focus in executive leadership from American Sentinel University. So congratulations, Dr. Willard. Yes, and she's going to share with you our 2018 training calendar. So take it away, Ruth.
Good luck.
Alrighty, thank you. And I'm just going to go over the Kentucky TB program training calendar, and that's one of the goals of the Kentucky TB program is that we actually provide you the training and the resources that you need, not only for your local staff, but for our providers that we have in the community. So first up that we have coming on March the 29th, it will be in Bowling Green at the Sloan Convention Center. And just note the time, it is Central Standard Time. We'll start registration at 10:30. It will go through 4:45. This is a training that's sponsored by our Regional Center of Excellence, Southeastern National Tuberculosis Center with the University of Florida. And they will be presenting the Kentucky TB update for physicians and clinicians. Again, registration, pre-registration is required. This is a free offering for you, and we will be offering CMEs and CEs for it. And our audience that we're looking for is physicians, clinicians, nursing, any personnel in the realm of TB. And this will be interactive training, and we'll have lecture and case presentation and time for questions and answering. So the link on the bottom is actually an active link for you. So if you'll go there and register, right now we have over 40 participants that's registered, and we will be limiting this probably about 125, 130 is going to be our max that we have. So if you plan to attend this, we'd like to ask you to go ahead and get registered as soon as possible. Another training that we have coming up will be on May 9th and 10th. This is going to be a training that we'll offer here in Frankfort, and it's our TB 101, it's our orientation. And we ask that all new local health department TB coordinators and support staff in the realm of TB to attend this training. We offer it twice a year. This is our first one in May. And one thing about this is that there is prerequisites that's required. And so you're going to have about, depending on how you do your online learning, between 6 and 10 hours of online learning, completing the CDC self-study modules on TB, and then review of the current treatment guidelines and the MMWRs on TB testing and contact investigation. Happy to say that we have revamped this TB orientation, and all the curricula is updated so that we're not repeating information, we're just reinforcing the information that you get in your prerequisites. And we've also added some innovative and some interactive sessions in this, so that you'll be able to take this knowledge and back and share it with your local health departments. The train ID is listed here, so I do want you, if you plan on attending this, you should have already received an email from me, and your leader has also received an email, so I'd like for you to go ahead and get registered. We've also updated this registration so that you will do your pre-test prior to the class on train, and then you'll also do a post-test and evaluation on train. So it's all online. You will not need to fax to me anything. So next we have a training, and we worked on this training again with SNTC. They'll be sponsoring this along with some of our local health departments. And this is the TST Train the Trainer course. Over my last few months that I have been here, one of the things that I have heard is that when we get suspects and we get things called into the health department, and that they have an abnormal or a result from a TST, is that we always ask is who administered the TST, and was it a reliable reading? And so we're bringing this training in to really increase our competency that we not only have at our local health departments, but that we really have out in our communities. The first training that we're going to have is going to be on June the 4th, and it's an 8 to 5 training. This will be a lecture and a hands-on training, and this one is going to be co-sponsored with the Green River District Health Department in Owensboro, Kentucky. And again, we are looking at nurses and physicians that are currently proficient in TSTs, and that we want you to come be a TST trainer. And we're really targeting our local health department TB coordinators, our nursing faculty in the area, our long-term care nurse educators, infection prevention, and employee health nurses. Just note that this is a free training to you. However, we are limited to 25 participants in the area. The link that's on there, registration will be through SNTC. As of close of business yesterday, we were working on getting these links active so that you can register for that. So if you log on to the link and it's not there, I would just say, just check every day because we're working on getting those links active. The second TST Train the Trainer course we're having is going to be here in Frankfort. It's going to be with co-sponsoring with the Franklin County Health Department. We'll be at the Annex. It'll be on June the 6th, 8 to 5. And once again, we're targeting the same audience, but this registration is limited to 25 participants. So if you're in this area and if you're at the local health departments and you reach out to your nursing faculty, just make sure that they're checking back at this link so that we can get them registered so that they'll be able to attend. The third TST Train the Trainer course we're having is actually going to be down in London, Kentucky, and this one is going to be co-sponsored with the Laurel County Health Department. It's going to be June 8th, 8 to 5. Once again, the same audience that we're going to have there. It's going to be interactive. Just make sure that if they are wanting to attend, that they're checking that link, they're getting signed into that. And again, we're going to limit that to 25 participants. On this last slide that we have here is our contact us. Again, my email, telephone numbers there, as well as the rest of the team that we have here. Some of the other things that you're going to see that would be coming from the Kentucky TB program is our newsletter. We've just recently revamped our newsletter. It's now the Kentucky TB program, The Dot. And lots of great information that's there, and this information that's really usable not only to the local health departments, but to your providers and to your peers and colleagues that you have out in your community. So if they're not on the listserv, I would just ask you to share that with them so that they get that information that's there. And also, I will be sending out to our local TB coordinators our World TB Day. I'll send you a toolbox. We have so far got a Kentucky-specific TB poster for you to be able to print and display. We'll also have updates on our proclamation and our press release, and we'll give you some ideas and some activities that you can do, as well as we want to make sure that you share those activities that you do so that we can highlight you, and not only in our newsletter, but also within our program. And so, and I'm going to defer to my team. Have I left anything out, team?
Are there any questions from the field for Maria? Or Ruth, excuse me?
Ruth.
Okay, doesn't look like it. Yep. Okay.
Thank you.
Thank you so much, Ruth, and congratulations. Appreciate the training opportunities. As you all know, that's administering the TST test. That would be certainly need to be provided by an individual who is trained and as far as and being competent in that regard, so reliable results can be recorded. I also wanted to thank Emily and the team for participating on the respiratory plan work group. As Angela mentioned, we've pulled together some nurses and program folks from DPH and a local health department nurse from the NEC, Kathy Gifford. Thank you, Kathy, as well as the OSHA representative from the Kentucky Department of Labor. And so, as you all know, N95 fit testing, that transcends and is bigger than the TB program. It's also applicable and relevant in the preparedness program and also in our hospital-acquired infection program. So we're working towards our goal is to have a comprehensive and consolidated guidance and training information for local health departments. And so we hope that will be beneficial for you all. And as Angela said, we'll be working on that at the next NEC meeting. And so I appreciate your all's input and the time and energy to pull that guidance together for the local health departments. So as nurses do, the first thing that we always start out with is a needs assessment. And so as Angela mentioned, we're going to start out with that survey, and we'll hope from that information that we compile, we'll be able to determine the most appropriate next steps. So thank you very much. Appreciate it. I am looking for my next presenter, and so they aren't here yet. So what I'll do is go ahead. I've got a full page of information to share with you all. So I wanted to go ahead and I'll take use this time to provide a quick commercial break for you all. I wanted to remind everyone about the HRSAP Summit. I sent out the information yesterday afternoon, and HRSAP, if you're not aware, it stands for Harm Reduction Syringe Exchange Program. Kentucky now has the most HRSAP programs of any one state in all of the United States, but we still do have a ways to go in having more of our communities have this resource available to the individuals in need. So I wanted to let you all know that the conference again is March 13th, which is a Tuesday. It's going to be held in Lexington at the Embassy Suites. It's free of charge. Registration is now open. So we're going to have two great panel discussions. One is going to be one panel is going to be comprised of local health departments who will be able to share with everyone, all the participants, and we do expect, hopefully, we're hoping for a large crowd, about 300 participants. But one panel will talk about barriers that they encountered and their solutions on how they resolve those barriers in setting up a HRSAP in their local community. And then the other panel is going to talk about promising practices, what they feel that they've done right and what they want to be able to share with other local health department, public health partners. So those two sessions I think will be real helpful. There will be data sharing. There will be a session on data collection. There will be vendors on treatment resources. So we'll have plenty of time for those breakouts to visit the vendors, networking with local partners, both public health partners and then from the county judge, executive, law enforcement individuals who will be there as well. The conference is sponsored by the Department for Public Health as well as the Office of Drug Control Policy within the Cabinet of Justice. So many of y'all have heard Van Ingram speak or know of Van's work, and so he and his office are a co-sponsor in this event. And so we hope you all can join us, either if you already have a HRSAP or if your efforts are to develop and implement a HRSAP in your community. We'd love to have you participate. If you have any questions about the conference, let us know. And there's room information, hotel room information that was included in the email that went out last night. So you'll want to check on that. There are some hotel scholarships. Next, I've got my TB scarf on here and it's making me hot. I'm sweating. It's about 60 degrees here. So then we've got on April 19th, I want to share for our next public health nursing webinar. That session will serve as our annual women's health update, the 3-hour women's health update that individuals that we require of individuals who work in women's health. That training will be on April 19th in lieu of the public health nursing webinar with various subjects. We'll have it focused all on women's health. So that will be April 19th. And it'll be archived in case your staff is not available to or not able to attend if they're out in the clinic. So I wanted to make sure you knew about that. Mark your calendars. We'll be talking about HPV, mobile mammography, and a couple other topics. So it's going to be with the trainers. The sessions have all been confirmed, and we're looking forward to that session as well. Wanted to also remind you all about KPHA, which will be held in Northern Kentucky this year. The Public Health Nursing Luncheon will be Wednesday, April 25th from 11:15 to 12:45, excuse me. And so 11:15 to 12:45. And the conference this year is on sustainable communities. And so we're looking forward to, No, I'm waiting for you to come.
Oh, okay.
Yeah, don't leave. I'll would have to extend my commercial break.
Oh,
So anyway, we're looking forward to the public health nursing luncheon and seeing everybody at KPHA, and we're hoping you can join us for that. I know they're working on the agenda right now and on the sessions, and some more information I know will be coming out from KPHA. So next, I'll go ahead and I'll stop there with my announcements. Our OATS partners are here to speak to us about the process where we are with the EHR system and the request for proposals or request for information. So first of all, I'll introduce the program manager, who is Shannon Bishop, who many of you all may know. And Shannon, thank you to you and your team for being here today. And if you'll just kind of provide us an overview, an update from what's happened since ECW was taken down, and now the process looking forward, what local health department nurses in particular and directors can look forward to in
okay.
regards to electronic health record.
Okay.
Thank you for being here with us today.
You're welcome. We're just going to do a brief update because things are happening really quickly. Like Joy said, my name is Shannon Bishop. I work for OATS. I am detailed to the Department for Public Health for the EHR project. So as you all know, we implemented ECW in some of the counties, and then that got pulled back. So we also went through some internal process about the database that we had for ECW. We've got that in-house, but I even got a request today from somebody at one of the health departments who used ECW who needed a patient medical record. And I just want to say that it's not, we do have the data here. I think it's on a COT server somewhere. But just know that data, it's not like we can dial, log into ECW and get the data that we want. It's all raw data. It's in tables. It's not easily accessible. So I am trying to do what I can to get some information for this health department. And if you're listening, I'm working on it. But just know that it's not readily available to get any of that historical data, but we're doing our best to get it for you. The other thing is what we're doing is, we were launching forward into the RFP process. And for those who don't know, that's a request for proposal. So that's like starting all over. So, going through procurement, following all the guidelines of procurement. There's a team that's on the RFP committee. And there's stakeholders from public health, from procurement, from OATS, all those people. But before we wanted to do that and put some RFP on the street, we wanted to make sure that everybody had their say about, and everybody had to have the opportunity to look at some vendors, and there's all this unique things going on in public health, and we want to make sure this time that we cover all bases. So we put the brakes on the RFP process, and then what we're doing is the RFI, which is a request for information. So what that's going to do is that's going to let the committee and the various stakeholders, we put together a document of all the unique, in general, all the unique qualities that we want the EHR software to be able to do. Functionality, reporting, interfaces, all that kind of stuff. And then once that RFI is on the streets, then there would be a committee that would be, seeing demos of vendors, trying to figure out what's out there, what vendors can, give us a public health software totally geared toward public health and all the other components that are involved with that. So right now in the RFI process, what we have is we have a draft, and we have distributed that, but we haven't given people a lot of time to review it yet. Actually, I distributed it on, Tuesday.
Okay.
And so we're going to have a meeting today with the committee, and we're going to review that draft. But there's going to be several iterations of this draft before it even gets to a place where it gets to the street and these vendors are notified that an RFI is out there and that they can, reply with questions, and then they can request demos, and there's this back and forth. So with all that said, there's no timeline yet. But I can't speak for the commissioner, I can't speak for Oates, but we want this to happen quickly because, the longer we wait, there's so many other components that we have to take into consideration. So no timeline yet, but we're working as fast as we can.
Would you mind to speak a little bit to the composition of the RFI committee?
Okay, so we've got representation from public health and the programs, different program people. We've got representation from the local health departments. We've got several directors, and they have a subcommittee that they formed, and they're reaching out to all the other local health departments and giving surveys and things like that to make sure that those local health departments have a say in this go-around. We're trying to get buy-in from everybody. We know the things that happened with the implementation in the past. We've learned from it. We actually have a document called Lessons Learned. We've learned a lot. We learned what not to do, and then we learned what we want and what we're not going to settle for. So also there's executives on the committee from public health, from the deputy commissioner to a lot of different directors. Then there's executives from, sorry, my phone's ringing, from Oates and from procurement and from COT. So it's a big group, and everybody had to sign confidentiality agreements because it's very confidential, because we don't want any vendor to say they had a leg up on anybody else. So does that help you, Joy? With
Yes, yes, that's very important information. Thank you for sharing that.
Okay, and then as we get weeds of this, I think once we can kind of get the final iteration of the RFI and procurement gives its blessing, and then it has to go through finance and all that other stuff. Once it gets on the street, I think this process will move more quickly, because then we'll be able to get in front of some vendors. We'll be able to weed out the vendors that we know just won't fit our needs, and then really focus on the RFP. We've already got a lot of requirements. We're having meetings in parallel with different groups to make sure that on the RFP side with the requirements, that we capture all the unique needs of whether it's program level, local health department level, DPH level. We've got all kinds of stuff going on. So are there any questions or anything? Will I know that?
Yeah, there.
Okay.
I don't think there are any questions.
Okay, hopefully that's a good thing that there are no questions. So,
Can you speak to a little bit as far as the RFI, and I think you touched on this, but expound a little bit on what the RFP will include as far as functionality and technical information versus training, rollout schedules, that part of and systems change, requests, that type of thing. That'll come after the vendor is selected. Kind of talk about that, how that will all roll out.
right. So think of the two processes kind of like, and Stephanie always says this, the RFI process is kind of like you're shopping for a new car, seeing what you want, seeing all the the bells and whistles, seeing what, just making sure that, the core needs are met, but then also making sure that the other things that we need are on there or not, and then kind of prioritizing the vendors. That's all it is. It's kind of shopping around. So the RFI document obviously is a lot shorter than the RFP document. The RFP document really gets into the weeds of everything. So we've got requirements, spreadsheets of requirements, whether it's requirements for Joy's team and what we need in specifics, that the functionality needs to do this. We need to be able to run a report that, everybody knows about ROM's report. We need to make sure that those data elements are included. All of that stuff is included in the RFP as attachments. So part of the RFI documentation will go into the RFP, but then it's like deeper.
RFP also includes money.
Right, and RFP talks about money and contractual things. Professional services would be one of them, which would include implementation resources, support for implementation. It would include how the implementation will be rolled out, it'll include training, it would include cost, licensing, all that kind of stuff. RFI does not get into cost. RFP does everything. So does that help?
Yes, and then as it relates, if I was a local health department nurse and I was interested in how the documentation would work with a particular EHR system and how the training will work and how the, if there's gonna be a rollout process and so what that looks like, how will that information be disseminated and decided upon?
Well, that would be in the RFP, the request for proposal with the
Okay.
requirements that we have. And then we're gonna vet that information out through the RFI process.
Okay.
Because depending on the vendor, they'll have different methodologies, the way they deploy their software.
And there will be demonstrations, will there not? of
Yes,
this
there will.
particular-
Yes, there's gonna be a lot of demos. Like I said, the team's tight, and it might be your responsibility to make sure that you go to your director or you go to your, the nursing supervisor or something and say, we gotta have this. And then funnel it all through, your management team, and then it'll end up getting to us. And if it's something that we've already got on the list, we'll make sure that that it's there. We've got that. But there's a lot of new ideas out there that people, there's like, I want to have, I wish I had, I wish we could do this. And then there's stuff that it has to do this in order to meet guidelines. So we're trying to make sure that we capture everything. That's why we're having these parallel meetings to make sure that the uniqueness and the context of the requirements are captured. So, because we see a requirement and we're OATS IT related. When Joy talks about a requirement from the clinical perspective, I mean, I get it, but I'm not a clinical person. So I have to make sure the terminology is there that captures everything that Joy wants from her perspective. Does that make sense?
Everything that the local health department.
Yeah, anybody's perspective, because there's so many stakeholders with this project, and
Right.
everybody needs to have a say, because we got to make sure everybody buys into this, because in the end, we all want to be more efficient, more productive, get more money in the door, all that kind of stuff. So now, are there any questions?
Did Deanna or?
Do you guys want to say anything? We've got Deanna Salih here. She's one of our business analysts, and we got Stephanie Westbrook here. Her name used to be Hudson, so if you see differences, you can talk to her about the name change. But she's on our team as well. So anybody, if you've got relationships with them, if you got a relationship with me, you can send it to me or whatever. All questions are welcomed because we need help. Who do we contact with our suggestions? Hi, Ava.
Nancy's on the committee.
Okay, Nancy's on the committee, Ava, so you can funnel that through Nancy, but you can also always use my team. Send the questions to me. Shannon Bishop. Any other questions? Joy, did I meet my time limit?
You're fine. You're good. You've got
Okay.
extra time. Do you want to talk about it?
No, I'm fine. We're off to another meeting.
Okay,
Thanks,
thank you.
Joy.
Thank you so much for coming by. Appreciate it.
Are you getting ready to present? Oh, then I'll talk to you later.
And he's getting ready to, he's next on the agenda.
Well, we were talking about you.
Thank you, Shannon and Oats team, and I'll see you later on this afternoon.
Yeah, and just contact us with anything.
Okay.
We'll do it.
Next, we have Sivaram Marata, or Ram, from the Kentucky Women's Cancer Screening Program. And Ram's going to share with us some updates about some KWCSP reports and some new codes. We're working on some new codes that have been approved by CMS. And so he's going to give you an update on the progress of getting those implemented in local health departments. And I always love it when Ron presents because he always dresses up and looks so professional with his coat and tie on. So Ron, thank you for coming today. We've got your presentation here already for you. And thank you for sharing information with the team. Okay.
As Joy said, I'm a tie and a coat. Thank you very much, Joy, for the introduction. You have always been a very great support, and a very champion of the department and the team. Okay. Want to thank you all for joining this public health nursing webinar, and I'm Sivaram Maratha. I go by Ram. I'm an epidemiologist, data manager with the Kentucky Women's Cancer Screening Program. I want to once again thank you for joining the webinar. And what I would do is kind of go over, give you a kind of refresh your memory on the history of KWCSP, eligibility, funding, grants, and also talk a little bit about the challenges and request your help and support in addressing some of those challenges that we have related to the data, and also talk about some of the audit reports, and also kind of share some updates on CPT codes. For all those folks who are new, history of KWCSP, the program started in 1991 using state funds. The CDC funds became available in 1998. And as you know, the breast and cervical cancer treatment program administered through Medicaid, we work with collaboration with Medicaid, started in 2001. I want to share some, I want to thank you all. I want also congratulate you all that so far with the collaboration with the BCCTP, we have referred approximately, well, I should say at least 6,500 women for treatment services. So these women have received treatment services for cancer or pre-cancer of breast and cervix because of your excellent effort, because of your passion, and to provide an excellent quality of care to those patients. So once again, thank you very much for all the services. As you know, KWCSP provides services in all 120 counties. Sources of funds, fiscal year 2018 CDC, we received approximately $2.5 million from CDC. Once again, the KWCSP eligibility is 21 to 64, no Medicare, no Medicaid, no private health insurance or any third-party payers. Women should be at or below 250% federal poverty levels. Again, as a note, KWCSP is reimbursing for family planning program PAP test. And we have been doing it for last 2 fiscal years. CDC grant requirements, as you know, if you can go back to the slide, we receive around $2.5 million from CDC each year. And some of the conditions or requirements from CDC is that we provide an excellent quality of care to the KWCSP patients, and we are doing it. And you have been doing a very excellent job in providing a top quality of care to the patients. We have been meeting all the CDC's core program performance indicators related to the quality of care. And we have been doing it for the last 15 years. We never missed any of those performance indicators related to the quality of care. So once again, congratulations and thank you for doing such an excellent job. We are one of the very few states who have met all these performance indicators for the last 15 years. So this is a very proud accomplishment. And again, this reflects on your commitment and a passion to provide an excellent care to the patients. Okay, let me go back. Submit other grant requirements are to provide an outreach to priority population, which includes Appalachians, African Americans, Hispanics, and women who have been never or rarely had a PAP test for cervical cancers. The other requirement, as you know, we need to provide data to CDC, and data has to meet 3 conditions. It has to be timely, it has to be complete, and it has to be accurate. And we do the data submissions to CDC twice a year. One is on April 15th, and the other one is on October 15th. And it is a grant requirement that we provide this MDE data or minimum data elements to CDC. These data elements, we collect this data from your registration screen, and also most of the data comes from the ACH 58 forms. So it is very important for you all to complete those ACH 58 forms on a timely basis, and also to input the data in the CDP system. MD data is required for PAP test performed through a family planning program. As said in my earlier slide, KWCSP is reimbursing for those PAP tests. So we have to provide the data to CDC on all women, on all KWCSP eligible women who received a PAP test through the family planning program. So MD data challenges. So request your assistance, request your, as you always supported and provided us the information. This is kind of just a friendly reminder to all local health department staff. Please review your pending mammograms and Pap test results on a routine basis. Look at the KWCSP through CDP provides audit reports or feedback reports to all health departments each month, and these reports can be downloaded from CDP e-reports site on 10th of each month. You should, if you go back and look in your e-reports folder, you will find several reports like 323 report, which is a PAP log, 676 report, which is a MAM log, and there are a few other reports which I will kind of go over in the next few slides. Please look at these reports to see if the results are missing for mammograms, PAPs, and HPVs or ultrasounds or any of those results. If they're blank, please complete those results, because the data from those results are feed into different other reports, so CDC reports. So my request is that if you can please review those reports on a monthly basis, download those reports on a monthly basis and review them and complete the missing results. It will be of great help to us. And also,
Ram, I have a comment. When if a local health department employee, if they have not been in the CDP reports files before and they need access or to log on, how would they get that access?
Yes, they can contact CDP to download those reports, or they can even contact us or local health operations, and we will guide them to download those reports. And in fact, if they call me or any of the staff here, we can walk them through those reports and show them, train them on how to utilize those reports and what those reports mean and what those variables mean. Yeah. So, and we can also show them how to key or to enter the data. Yeah. So,
thank you. There's lots of turnover with the nurse, local health department nurses, and new staff are often coming on. So I just wanted to make sure that we were always available. Let local health departments know we're always available to help them gain access to those reports and teach them how to use them.
And actually, I was looking at the February and January reports. Joe, I think they've been doing a very fantastic job in cleaning and completing those records. Many health departments had just maybe 4 or 5 records.
That's wonderful.
One of pending, and but just want to kind of take this opportunity once again. Please review those reports on a monthly basis. Look at your reimbursement reports that are available to you all. So always please call if you do not know how to download those e-reports or do not know how to kind of work on those reports. Please call us, and we will be very glad to provide you any technical assistance you need to run those reports. Again, the other important point is that ensure completion of ACH 58 forms. Please complete ACH 58 forms on all KWCSP eligible patients, and also women who have been receiving PAP tests through a family planning program. So because the KWCSP is paying for those PAP tests for all the family planning program patients who are eligible for KWCSP. KWCSP audit reports, 3 main reports I would like to highlight in my presentation today. 1706 report, again, this is an e-report. You can download it from CDP site. This report provides a list of all diagnostic pending records for breast cancer. If a woman had an abnormal CBE or a mammogram and she had a diagnostic mammogram or ultrasound or MRIs or biopsies, and you have not filled out an ACH 58 form on these patients or for this section of the diagnostic section on the ACH 58 form, you will have this. You will have a record of this patient on this report. So if you find a record on this patient on the 1706 report, it means that her diagnostic services have not been keyed in. Her final diagnosis has not been completed, or her treatment information is not being keyed into the system. So please review the 1706 report to see if there are any pending records related to the breast cancer. And the next one is similar to the breast cancer report, but this is about cervical cancer. You'll find this report will list all diagnostic pending records related to cervical cancer, related to colposcopies, related to leaves or cold knife wounds, if they are as a part of the diagnostic services. So this is another 1707 report. The next one is 1709 report. This is one of the challenges we have right now is that 1709 report. This report provides a list of all breast and cervical cancer records that have incomplete MD data or records that need to have MD data collection screens. What it means is that if a breast CB results are missing, if a mammogram results are missing, if a PAC test results are missing, if HPV results are missing, or the diagnostic workup is not yet determined. So this report will provide you a list of all those records where KWCSP, these are all KWCSP, these reports are all on KWCSP eligible women. So run this report every month. We have for the last 3 weeks, we have been reaching out to several health departments, asking them, requesting them to complete. We got a very wonderful response from health departments and nursing directors. They just faxed us all the data, ran the reports, and they called us. Ram, we completed the records. They reached out to the staff, and several health departments said, Ram, can you please help us to complete these records? Can you walk us through these reports? Can you walk us through those patients and can you help us complete this data on the screens? I'm so thrilled. I'm so thrilled and excited when you ask me those questions, because it shows that you are trying to work out. And I've seen health departments with the reports having just 1 or 2 records, and that too from very recent times. So very, very excited. Thank you very much. But once again, please complete these records on a very timely basis. One of the reasons why we need to we are emphasizing this today is CDC is updating their software, and they're changing the MDs, MD data elements. So we got a request saying you got to complete these records as soon as possible, clean it up, so that when you move on to new softwares, we want you all to start very clean. So we want to get these records updated in the system and in the MDE file. And also, this is a requirement from CDC. What CDC would do is that take the MD data from us, look at how many services we are provided, and they will determine the funding for the next fiscal year. So this MD data that you are providing through a CDP system helps us is directly connected to the funding for the next year. So please help us in working on those reports. CPT codes. We are working on the CPT codes. I've received several calls and emails from health departments asking about the CPT codes, especially mammogram CPT codes related to CPT code 77057, 77067, and GO202 CPT codes, and also the rates. We are working on it. We are at the final stages of completing, revising the CPT code list for calendar year 2018. By close of business next Friday, you should receive an email with an updated version of the CPT codes.
Tomorrow?
Sorry, not tomorrow, next Friday. Thank you, Joy. Next Friday, I mean not this coming Friday, but the next Friday. So we will provide you that list, and you will see the changes, some very welcoming changes, like removal of CPT code 77057, and some of the G codes are no longer there, and a new updated rates where we will be able to provide you more funds for the services. So please look forward for that attachment from us on the reimbursements. Here's the contact information. Ellen Bernard, she's a program director. Colleen is here. She is a clinical coordinator. Holly Mullins, she is a quality assurance consultant for the east side of the Kentucky. And Regina Reed, she is a quality assurance consultant for on the western Kentucky. So you all have spoken to us several times, so know that, but just give you the contact information and the email. So always feel free to call us, email us. If you need any question, if you have any questions or concerns, or you need any assistance from the program, we receive calls and emails almost on a daily basis from health departments. Please do not hesitate. If you have any questions, please let me know.
I have a question. I have 2 questions. Ram, so if a local health department, if they completed all of their audit reports and there weren't any names on those audit reports or from CDP, that means they would not receive a phone call from you. Is that a correct statement?
Yes.
Because that's when you would call,
Yes.
is if that audit report had not been worked,
Yes.
and there would be names that still had missing data.
Yes. Thank you.
I'm just trying to connect the dots
Yes.
for perhaps some of the new nurses.
Yes, one of the reasons I would call the health departments is that if if the record that's pending on the audit report has been there for a long time, so what I would do is call them to see if they need any assistance in completing those records. Some records from, for example, November or December of 2017 are going to be pending because the patients are still in the process. So I wouldn't call on those cases. But if the record is from September of 2017 or prior, more than 6 months, so what we would do is call to see if what exactly has happened, if they need any assistance, or they're having data issues, or in trouble entering the data. So usually if a record has been on the report for more than 4 or 5 months, then it would be a kind of trigger for us to see if they health departments may need some assistance in completing those records.
Because there is truly a time when those records will be pending.
Yes.
Yes.
The second question?
My second question is, I'd like to invite you back to another public health nursing webinar to talk about the MDE changes.
Yes.
And can you address just a little bit and briefly what you know about the revision so far? Ron?
Yes, Joy, thank you. MDE changes. CDC has taken our feedback. We provided feedback to CDC over the years, asking them to review the number of data elements they have been collecting and requesting from us. So CDC, we provided continuous feedback. The last year, we gave them more active feedback. So based on our feedback from not only from Kentucky, but from other states, what CDC has done is that they said they're going to review those data elements. They're going to remove some of the data elements that are no longer needed or causing a lot of inconvenience. So what they said is that we're going to cut some of the data. We're going to remove those data elements, and we'll revise. We'll revise on those forms. This February 28, we are having a webinar from CDC providing us the details about what data elements will be removed and how they're modifying the current data elements, and also if they are collecting different data elements, and also providing more clarification on how to collect certain data elements. So what I will do is provide you more details in my next webinar and changes in the MDE. So we should have a less number of data elements to collect. So from the next during the next changes. And our goal is always provide us feedback, give us feedback. Say Ram or anybody here in the staff say, this data element doesn't make sense here. No, it's not accurate, or we can modify the form. We can make the data collection form, which is ACH 58 form, more friendlier, more user friendly. Please provide us feedback so that we can improve the program, we can improve the data collection process. We want to make the data collection process more smooth, more timely, and more easy for you all.
And then lastly, on the CMS, on the new rates, can you talk to us a little bit? We do anticipate there are going to be some rates that are going to be increased.
Yes.
And some codes that will be deleted.
Yes.
Right. And so I'd like for you to talk to us a little bit about that as far as incorporating the new codes into local health departments, contracts
Yes.
down.
Yeah. So we should, as I said earlier, we should be able to send you new updated CPT codes with the new rates. Rates have increased for several CPT codes. As Joel says, some CPT codes have been deleted, but there are rates for some CPT codes have decreased. So what we're doing internally is working out those CPT codes that have got the rates have decreased. As I said, 77057 CPT code is there are changes to those mammogram CPT codes, the CAD CPT codes, and then so we should be able to provide you a very good comprehensive list of all approved CPT codes with new rates, the decreased or increased rates to you by next Friday, and I look forward and see and we'll provide you some directions on the contracts. You may amend your contracts and or maybe wait until some time to work with your contracts. We will leave up to you, but we will provide you some direction on how to go about with those contracts. Thank you, Joy. And always your questions are very wonderful.
Are there any other questions from the field? I didn't mean to monopolize the floor there. I was just trying to pull some information out of Ron for you. We do understand that the contract piece with as it relates to the CPT codes and the rates is a time-sensitive issue because contract time is right around the corner. So that would certainly be up to each of the local health departments to determine when you want to incorporate those new codes and reimbursement rates, if you want to modify your 18 contracts, or if you want to wait until your 19 contracts and include those new rates to be effective July 1st. But that certainly would be up to the local health department, but we want to go ahead and get that information out to y'all in a timely fashion so you can have that information for your subcontractors. Yeah, okay.
Thank you.
Thank you, Ron. Is this your water?
Yes.
Okay. Colleen, do you have anything you'd like to say today?
I don't have any.
Okay, all right. I wanted to remind everyone that the nursing CEs for today's webinar I believe is 1.9 CEs. Is that right, Tony? I forgot to put that on the agenda today, so you'll want to be sure that you've registered and completed the evaluation for the 1.9 nursing CEs. And also there will be awarded for the HRSEP conference 6.8 nursing CEs. I forgot to mention that, so I want to be sure to share that information with you. I also wanted to talk a little bit about where we are with the administrative reference and the CCSG revisions. The administrative reference, or AR revisions, that work group is comprised of DPH and local health department participants. And right now, DPH by division and by program and by chapter of the AR is going through and reviewing that information. They're submitting that information for review by local health department leadership, and it will be available by July 1st. So if you happen to know of any topics or concerns or questions about the AR, I invite you to send those to me if you want to, and I can, if you want to send them to me or the program person, that'll be fine, and we'll make sure they get to the appropriate person. The AR includes a wealth of information. I know as busy nurses, sometimes you all don't have the opportunity to get into the AR and look around at 1,000 pages, but there is important information in there. It's a great resource, and especially for nurse leaders, there's information in there for from administrative perspective. Then I wanted to share with you the Core Clinical Services Guide revisions. I'll be sending out that email hopefully this week, if not by tomorrow, by next week. And I'll be asking DPH program leadership to review their CCSG chapters, make sure that the guidance and the clinical expectations that we share, the protocols for local health department nurses are timely, relevant, and they're up and current with the national standards of care. So all that information will be coming into me to the nursing office, and then we'll be reviewing those proposed revisions with the Nurse Executive Committee. We'll do that probably in March and April. So the CCSG will be updated effective for July 1st as well. So I just wanted to let you know both of those guidance documents are they're in the process of being reviewed, and look forward to some revisions and changes. And we'll be sure to have webinars or updates for you all to share what has been changed, what's been revised, what's the latest protocols say. So next I'd like to introduce Matt Johnson. Matt, if you want to come on up. Matt is an assistant division director with the Division of Laboratory Services. And Matt has graciously agreed to stop by. You know, the lab is not on our campus, it's down the street a little bit. But I wanted to invite Matt to come and introduce himself, and we're going to talk a little bit about what we're working on as it relates to DLS resources and materials. And I'll hush Matt and I'll let you talk. And I've got our list here kind of that we can go through if you want. But Matt's been a wonderful partner. He's attended 2 NEC meetings, or going to be attending the second NEC meeting next week. He's very proactive and an advocate for local health departments and getting information out to you all to the field. So I feel like we've got a great partnership and a relationship with Matt.
Sure.
And so thank you for all of your support.
No problem.
And you, we could go through that in a second, but
Sure.
I want to give you a chance to say something without me being up there.
Well, hello all. Matt Johnson. I'm the new assistant director at the laboratory. Started actually January 1st of this year. I've been at DLS for almost 19 years, and I started at bottom rung, and I've gone through the whole scientist tree, management tree, and eventually made it here to the assistant director position. So I'm quite familiar with the operations in the laboratory, and when Joy reached out to me as a contact for the local health departments, I thought it'd be a great opportunity. I know that you've worked with other people in the past, including Linda Daly, now more. I've worked with her a lot throughout the years, so I always have her expertise to rely on. She is retired, but I have her personal number, so I can get a hold of her if I need to. However, things have changed with the laboratory and our relationship with the health departments. When you guys got your own individual CLIA certificates, things were kind of, communication chain was a little bit broken, and I'm gonna try to help fix that situation and make it as comfortable and easy for all parties involved. Joy and I have had a couple meetings together, and I kind of have an idea of what the issues you guys are working through, and we're gonna try to help you as much as we possibly can, allowing what our director is asking us to do. So having said that, Joy, let's.
You want to go through our list?
Sure, we can certainly do that.
Okay.
You can tell me what's on the list, and I can tell you what we're willing to do and what we're gonna do.
Okay. Well, let me start. Thank you, Matt. Well, I'll start with the list that we initially developed and that was proposed and sent to Matt and Dr. Hart, the division director of the lab, from the NEC.
Okay.
And so, and certainly that list is a working list, and there may, there's always opportunities for revisions and updates and changes. So,
Additions, deletions.
yeah, additions, yeah. And so we'll always be open and receptive to
Certainly.
accepting, input that goes without saying. So some real basic information that we wanted to work on and provide was, one, contact information for laboratory staff to be placed on the DLS website.
Correct.
So,
Now, I sent the contact list to you,
Yeah.
and I think you can
Yes.
send it out to everybody. So I don't know how much you guys know about the website, but it has to go through an approval process. So we are working on starting that process.
Yeah.
I'm working with Leanne Bates, who controls the website, and Dr. Hart to see exactly what they want on there and what he'll allow us to put on there. But I can guarantee you the contact list will be one of those things.
Yeah.
So it will be put on the website.
okay. And I think that will be real helpful, that in that it's organized by sections and the tests that are performed. And so
Correct.
if they have a particular question about a particular test, that's how the call list, resource list is organized.
Yeah, broken down by sections.
Yeah. Okay. Then I wanted to talk a little bit about templates.
Okay.
And we have various templates that have been requested. And as often is the case, local health departments have the resources. Somebody has a great resource for templates, or they've developed checkoff lists on their own or whatever. And so in this particular scenario, I wanted to share that the NEC membership, after we kind of identified the template need, we do have, I feel like, very good forms. There would be templates for all local health departments to use. Matt has reviewed those and given us his quote unquote approval.
Yeah, quote unquote.
Quote unquote.
Right.
Yeah. But So we're gonna have blank templates for the authorized procedure form, and you all know that as Joy Hoskins is qualified or competent to perform these tests.
Right.
And then Matt Johnson is qualified to perform these tests. So that template, we'll be sending that out. And there's 3 that actually Graves County, Kathy shared with us, 1 for local health department clinics, 1 for Humana for the Go 365, and then 1 for the school setting.
Okay.
So it's basically the same form, but just an acknowledgement that those forms would be relevant and appropriate based on those different settings. Anything you want to say about that one?
No, and I talked to Leanne, and she said a lot of these forms were previously on the intranet, but they were removed, not by our request. So we're looking at having those forms put either back on the internet or back on our website.
And what we found was that some nurses, as new nurse leaders have started their jobs, there may have been a wonderful binder of all the forms ever needed for a local health department lab. And then we've heard the complete opposite, that there was nothing available when that new nurse leader started. And so we're trying to build up and provide standardized forms and documents and resources for all local health departments. Another checkoff, another form is the new employee orientation checkoff list. We heard that from the NEC membership loud and clear that was a void or a gap that they wanted to address. The signature page, there's a signature page for documentation that this local health department used, where they would ask the employee after he or she had read the laboratory manual that they would sign that form. And so that's an internal form. You may or may not choose to use that, but it's a way to confirm and document that your employees have reviewed your agency's laboratory manual.
Correct.
Another template is the annual competency assessment checklist. Certainly that is a need for all local health departments to have, to assure and to validate and confirm that their local health department staff who's performing either wave testing or PPM testing is trained and competent to provide those laboratory tests.
Right.
Anything you want to say about those?
No.
Okay. Another resource is, and I shared this and at the last PHN webinar, and also sent out the links for the CLIA guidelines for both waved labs and PPM labs. And those books are developed by the CDC. And so I did reach out to the CDC, and they said we could have as many of those books as we wanted and needed.
Excellent.
So yeah, so I'll be placing the order for all local health departments to have a hard copy CLIA manual on site for you, depending on your CLIA certification.
Great.
We also reached out to the Office of Inspector General, who is the entity who is responsible for reviewing, monitoring, overseeing CLIA certifications. You all may know Marla Lyons. She is with OIG, and she covers the west part of the state. She's very helpful, very approachable, and very accessible. She's always responded quickly to my emails and my phone calls, so she's great to work with. And then Truman Taylor. I think Truman's new. I've not met. Is he new?
I think he's new. He also has another person that's going to be working with him.
Oh, good.
Shane Hardison, who actually worked at the laboratory years ago. And
really?
He moved to work for state police, and now he's come back. He got a job with OIG. I heard that he's going to be working more in this area.
In Central. Oh, right. Good. So we'll have 3 OIG points of contact.
I believe. I think so.
Okay.
I think so.
Okay.
I don't know if one of Marlo or Truman is going to find another position in that organization, but I was told that Shane was going to be trained to do the inspections.
Oh, good. Okay. So CLIA specific questions about your CLIA certification, compliance with CLIA, how to renew your CLIA certificate, problems with, your CLIA certificate number, so forth and so on, those questions would need to be directed specifically to OIG. And so we want to make sure that you all have their contact information so you can contact them and very easily. Then in those CLIA manuals, I'll share with you, there's some great information to be looking forward to. They have SOP templates in the manual, which that was another gap that was identified by the NEC. And so it's pretty generic, but if you use the lab test package insert and use the template, you've got what you need.
That's correct, yeah.
Is that?
Yeah, package inserts, really all you need. Work it into that template and it should be good to go.
Yeah, okay. Then another question that we had, and this so happened to be in the CDC guidance as well, the roles and responsibilities of the local health department lab director. I've received that question myself several times, and so I think it'll be good to have that point of reference and a part of the guidance that we provide to local health departments, so you can have that at your fingertips. And I know that varies from local health department to local health department and who fulfills that role, but I think it would be advantageous to have some minimum, guidelines, points of reference, to start out with. And then, of course, the local health department can add on as they deem appropriate.
Right.
Another part of information that will be, this is a resource actually that Robin sent to me. She said she receives a lot of questions about wet mount proficiency testing and remedial action for the failed PPMs testing. And so there's going to be a list of resources, and we'll identify what the resource information will provide to you. And she said that is an FAQ that you all receive frequently from local health departments. So we've got a website link there, and it refers to the Michigan, I think it is, wet mount proficiency testing guidelines. So that's what we have so far. I think it's a good, we've got an elephant. I think we've taken a lot of big chunks out of it.
Small chunks.
Small chunks. We still have a way to go, but I think from the list that we started at with the NEC and with the information, what we learned through this conversation is there's lots of information that the lab has. It's a matter of pulling it all together and
making it accessible.
Yeah. And so that's what we'll be talking about at the NEC meeting. Matt will be there. And so he's already on the agenda. So we're going to be talking about how to organize that information.
Right.
And then secondly, where would you all want that information to be housed? So, is it, should it be in local health operations on their website, on DLS on their website, on, in the forms, in the CCSG or the internet or intranet? So, there's a lot of different places that we've kind of kicked around, but I would certainly love to hear from you all if you feel like there's a one central location, and that's what our goal is, right? Where a local health department nurse, when she said, I need to look up laboratory information, where it would be the natural instinct to go to that place. So, so we'll be working on that on Tuesday, pulling together what we have and still identifying some gaps that hopefully we'll be able to wrap up. And then the goal is to have this information available in the July 1st edition of the July 1st when the CCSG and the AR roll out. If it's sooner than that, we can make it available sooner than that. What other, I'm sorry, Matt, were you going to say something?
No.
I was just going to ask, and I may have caught you off guard just asking you cold, but do you all have gaps or identified needs that you all would want to share with us today that we could address and follow up on and get those gaps taken care of? Nobody said anything? Okay, all right. All righty. Well, Matt, do you have anything else to?
Well, you can look me up on the global.
Yeah.
It's matthew.johnson@ky.gov. My direct phone number is 502-782-7729. Feel free to reach out to me. If I don't have the answer, I'll reach out to somebody that can help hopefully provide that information to you. I work with multiple people at the laboratory. It's not just me. I've got, Robin Cotton is still helping out. We have Bill Baker, who's more of our compliance officer now. So he would work with your CLIA questions and things like that along with OIG. But feel free to reach out to me either personally or through Joy. More than willing to help out and figure out a way that we can get all this information to you as accessibly as possible. Thank you.
All right. Thank you, Matt.
No problem.
And thanks to the Nurse Executive Committee as well for pulling together a list and helping us walk through that list and address those questions and comments and concerns. So, Matt, you're a great partner, and thank you to you and the lab.
Thank you.
Okay. This concludes today's Public Health Nursing webinar. We're running a little bit early, so that's fine. That'll give you some time to go ahead and maybe squeeze in some lunch today. So thank you for all that you do. Please feel free to call me at any time, and I'll be glad to assist you in any way I possibly can. Oh, good. Oh, good. Well, here's we've got WIC information coming up. So Marla, you want to come on up and talk? Okay, I sent out 2 emails yesterday. I don't know if you saw those, Marlene or not, that about the website and then about the birth weight loss charts. Yes. Okay. Oh, good. So come on up, Marlene. Good. Right. Okay. Thank you, Marlene. You caught us just in the nick of time. I was getting ready to let him go to lunch. And if you'll send that to me, Marlene, the presentation, I'll send that out.
All right,
Okay.
yeah. Thank you. Okay, today we're going to talk a little bit about some new and revised risk codes that has come out with the WIC program and you may be working with. Just a little background, how we develop the risk codes that you evaluate your WIC participants on and why they are what they are. The Risk Identification and Selective Collaborative, or the RISC, reviews a proposed criteria based on current things that's going on in the community and issues that we see with health of our participants. So the RISC committee develops these and proposes those to the USDA Food and Nutrition Services branch. Then they review and make final approval on those risk codes that we use to evaluate the WIC participants. And we had some new and revised risk codes that were implemented in October of 2017. If you work in the WIC program, we do have 2 webinars that are on Train, and the codes are on here. And these are going to go over all of the revised codes. I'm going to focus on one today, but these go over all the new and revised codes. They do have CPE hours and contact hours for dietitians and nurses for viewing both parts. Today, we're going to talk about slow and faltering growth. So we're going to talk about infants. So we're going to talk about those infants birth to 6 months and how to determine if their growth is slow or faltering. So with the new risk code, infants between birth and 2 weeks, we want to look at any excessive weight loss after birth as defined by USDA as greater than or equal to 7% of their birth weight. And then for those infants that are 2 weeks to 6 months, we look at any weight loss, because by that point, we don't want infants losing weight. But we need to use 2 separate weight measurements that are taken at least 8 weeks apart. So if you weigh them today in clinic and they're a little bit lower, we're not just going to use that one measurement to determine if they have slow or faltering growth.
So slower faltering growth is, we look at those rates based on infants' age and sex. So we know they have typical growth patterns, and that could be length, weight, or head circumference. We want infants' growth to be steady and predictable based on the growth charts, and the growth in infants reflect their health and nutrition status. So if they start having faltering growth, that's a concern that they may not be getting adequate nutrition, or there could be something going on. So timely detection of poor growth is a good way to make sure that babies don't get in trouble. Our goal is hope to catch babies before they get in real big trouble. We don't want to create undernutrition or have detrimental health outcomes. And this could be short stature, poor cognitive or educational performance, weight gain later in childhood as they're trying to catch up from where they didn't grow enough early, or nutrition-related chronic illnesses or diseases such as diabetes or something like that. So for WIC, the risk code assignment 135, for infants birth to 2 weeks, excessive weight loss after birth, defined as greater than or equal to 7% birth weight. So infant weight loss in the early postpartum period is physiologically normal. Most babies will lose a little bit of their birth weight after they're born. And so a weight loss of 5% is considered normal for formula-fed or breastfed infants. So we don't worry about those 5% weight losses. However, healthy infants are expected to regain birth weight within 8 to 10 days of their postpartum period. And then if they have a weight loss of up to 10%, that's the maximum acceptable range. So anything above 10% is definitely a concern. Things we looked at with contributing to weight loss after birth could be hospital practices, epidurals. Mom gets lots of fluid, so baby gets fluid. So the baby loses the fluid. If the babies are using pacifiers in the hospital, they may not be nursing or eating as often as they need to. Low or non-nutritive feedings or strict feeding schedules. Many times they're told, don't feed on demand, feed 15 minutes every 3 to 4 hours. So that may impact how much nutrition the baby's getting. Also for mom, it could be retained placenta, anxiety, poor maternal knowledge. Maybe mom don't know how to feed the baby or how much a baby should be getting. So we want to make sure that we educate mom. Infant factors can be the birth weight, gestational age, the feeding method, any illness or medical condition that the baby may have at birth. Breastfed infants, we want to really watch the position and latch and make sure that they're getting milk so that the baby is getting adequate nutrition from the breastfeeding. Breastfed infants that have a loss of 7% of birth weight in the first 72 hours after birth need to be evaluated. We want to catch these issues. If baby's losing that much weight that early, we definitely don't want them to keep going so that they lose more weight. WIC staff should assess and identify and address any potential underlying feeding issues that could be causing the newborn weight loss. And an infant that has a weight loss of 7% or greater signals a need for evaluation or intervention. That doesn't mean we need to send them running to their doctor. We just want to try to figure out what's going on. But if you do have a baby that has 10% weight loss, definitely refer them back to their primary care doctor for a medical evaluation. And if they're breastfeeding, refer them to lactation support to figure out what's going on. This is the birth weight loss chart that was sent out. And this is a reference for you to use in clinic. So when you're seeing that baby, you don't have to calculate an 8-pound baby, what is 7% weight loss, what is 10% weight loss. So this is just a quick guide for you to use so that you can do a quick and easy 8-pound weight loss at 10%. Okay, if they weigh less than 7.3, that's a concern. For those older babies, the 2 weeks to 6 months old, any weight loss is a concern, but we want to make sure we're using 2 measures, taken at least 8 weeks apart when doing that evaluation. While infants are expected to have slower growth rates between 3 and 18 months, weight loss is not expected after the 2 weeks of life. That's always a red flag. And any single measurement on its own is not adequate for identifying nutrition growth delay. So anytime you have a weight loss, that's a concern. So when you're checking the growth of infants, it's important to use standardized equipment and those proper measuring procedures to make sure that you get the reliability between measures. If you weigh the baby in a one-piece romper with shoes and a dirty diaper one time, then the next time you strip the baby down, the weight, they may have less weight, but it's not because they lost weight. They just have less clothes and a clean diaper on. So definitely make sure you're using good measures when you're checking that. Weight loss causes may include inadequate caloric intake. This could be from mom not feeding often enough, or maybe mom's concerned she's not going to have enough formula, so she's watering down the formula and not mixing to the appropriate mixing techniques. Normal caloric intake, but excessive loss or malabsorption, and this could be a medical condition or an illness. Any acute illness or dehydration, baby's throwing up, baby's got a stomach issue going on, any acute infections, any feeding problems, if baby has an allergy to milk protein, lead poisoning, HIV, infants can have caloric stenosis of the intestines, or any gastrointestinal reflux or any GERD can cause some weight loss. It could be a neglect issue, or it could be a measurement error. If you suspect faltering growth, you should assess for and counsel appropriately to address any potential needs. That may be inadequate caloric intake due to appropriate formula mixing. Make sure you're going over with mom. How do you mixing formula? How much formula is baby taking? How often is baby eating? Is baby throwing up after they eat? Or any breastfeeding problems. So assessing how's baby latching? Can you hear them nursing? Do you hear swallowing sounds? Are you feeding 8 to 12 times in 24 hours, or are they going 10 hours at night not eating? Early introduction of solids. Maybe at 3 weeks they decided to start gravy. So make sure that they're not substituting the formula or the breast milk for solid foods. Maternal depression, and then once you do that education and assessment, make referrals as appropriate. Infant weight gain pattern does vary by feeding methods. So when you think of breastfed and formula-fed infants, they do grow a little bit differently. Compared to formula-fed infants, breastfed infants are going to gain really quick. For the first 3 or 4 months, their rate's going to be a little faster. After that 3 to 4 months, their rate typically slows down. The weights of formula-fed and breastfed infants by childhood have stabilized, and they're pretty standard. We want to make sure that the slowed rate of the breastfeeding infants after that first 3 to 4 months are not assumed to be poor milk intake and that the baby's not getting enough. So we ask them to stop breastfeeding or introduce solid foods earlier than necessary just because their weight gain has slowed. This is just a standard of average mean values of gains for healthy breastfed infants, and this is from ACOG. And so this is just kind of based on how old the baby is, and for girls and boys, about how many grams per day babies typically gain on average. If you suspect abnormal growth, make sure you're screening for underweight, short stature, failure to thrive, or low head circumference if you have the head circumference measures. Make sure you're looking at the data to assess for accuracy, discussing feeding problems, improper formula preparation, and assess to determine if caloric intake is the issue for the insufficient growth to make sure that the baby's getting enough. And then also assess for any medical condition or developmental delays the baby may have. When you're counseling the mom, we want to use participant-centered nutrition counseling. We don't want to lecture mom. We want to have an open dialogue and conversation with mom and make mom comfortable talking to us. Provide or refer for breastfeeding support if necessary to a lactation specialist. If your agency has a breastfeeding peer counselor, do those referrals. Go over the Kentucky Infant Feeding Guides. There's also a good resource on WIC Works, and the website's on your screen. It's baby behavior, hunger, and satiety cues. So that goes through signs of baby's hungry and signs of the baby's full. And so sometimes mom don't know what baby's telling them, so they don't know they're saying I'm hungry. Appropriate introduction of complementary foods. Review of breastfeeding and formula feeding schedule. Find out how many times they are feeding. Formula feeding mixing techniques. And then based on your counseling and information, you want to refer to the physician, social services, home visiting, early childhood intervention program as appropriate based on your conversation with mom. Some information resources that we have for you that you can use and share with participants: our feeding guides, our kangaroo care, breastfeeding the premature infant, is my baby getting enough, human milk storage guidelines for those moms who may happen to be pumping, breastfeeding materials like Baby's Best Start, Getting Started, and Expressing Your Breast Milk. What if my baby's formula needs to be changed if they go into WIC and all of a sudden we're telling them you're going from formula X to formula Y? Smoking, alcohol, and drugs, and then the safe sleep environment. And all of our nutrition education materials is on the website on your screen. And these are just some references of where the material came from that USDA developed. And then here's a list of our contract if you have any questions about any of the new or revised risk codes that you can give us a call. Thank
Marlene,
you.
thank you so much for
You're
coming.
very welcome.
I emailed the WIC team yesterday afternoon and told them that we did have a few extra minutes on the agenda and invited them, and voila, here they are. So thank you so much
You're
for
very welcome. Happy to do
being
it.
here and sharing the information with the nurse leaders. I appreciate you. And if you'll send that to
I
me,
will.
I'll send that right out to the nurse leaders this afternoon.
That sounds great.
Are there any questions for Marlene? Okay. All righty. Well, if you think of something or talk to your WIC coordinators and they have questions, please, refer them to Marlene or the WIC team, and I'm sure they'll be happy to help you out. Thanks again,
No
Marlene.
problem. Thank you.
Okay, so that concludes the February 15th, 2018 Public Health Nursing webinar. Thanks for all that you do every day. Contact us anytime and we'll be happy to help. Have a great day. Bye-bye.